Angela, you want to take it away?
Yes. Thank you everyone for joining us today with our first launch of our CAMSA event. My name is Angela and my colleague here is Jacob.
Nice to meet you.
Yeah. So the mission of CAMSA, which stands for Canadian American Australian Medical School Association, is to provide a platform for medical students to expand their knowledge, network, and interest in advocacy, research, and medical specialization. I'd like to take the honor of introducing our first speaker, Dr. Baker, who is a professor of psychiatry at the School of Medicine at the University of California, San Diego. She spends her time on a combination of research, clinical work, teaching, administrative, and professional activities, primarily at the San Diego VA Health System and UCSD. Her main interests are PTSD, mild traumatic brain injury, MTBI, neuroendocrinology, inflammation, childhood trauma, and healthcare quality of life. So whenever you're ready, Dr. Baker, we would be delighted to listen to your talk.
I'll just kind of lay out how I came to become a psychiatrist and then leave quite a bit of time open for questions. In medical school, as you know, if you're being medical students, you have a lot of options within medicine, and you know, some of them can be quite attractive given your interests, and others less so. I had been interested in neuroscience really since college. I just found it fascinating, as well as I like talking to people. And so what ultimately directed me toward psychiatry is really those two things. I did my training in New York City at Columbia University, and I found that the psychiatry had a couple fascinating aspects. The first patient that I really was sent to see alone in my psychiatry rotation actually had bipolar illness. And one of the very interesting and positive things about psychiatry in New York City is there were a lot of cases, and somewhat extreme at times cases compared to what you might see on a daily basis. So the first patient who I went in to see on the inpatient unit, I was expected to do an interview and talk to this person, and this person didn't talk. I could not get a word out of him. And so I came back. I left and felt rather defeated and came back. But when I came back the next time, he came rushing up to me and he said, "I'm so sorry. I couldn't say anything to you. My mind was just going so fast." And then he kind of repeated a number of things I said, that when you said, "How are you?" You know, he couldn't interpret it, basically. He was telling me he was interpreting in multiple different ways, and it kept him from speaking. And so that was really my very first engagement with a real patient. And so that, with the interest in neuroscience, is what led me personally, ultimately, to do a residency in psychiatry. I actually matched in neurology initially, but due to family issues, I didn't move to the West Coast, and I ended up moving to the middle part of the country. And by that time, having done a medical internship in internal medicine, I realized how much I love talking to people, and that I really needed a specialty where I had the ability to engage. I had more time to engage with folks, you know, around their issues, not just around their medical aspects. And so I switched and entered the psychiatry program. In the program, I ultimately decided to do a child fellowship as well. and then hadn't really thought about research until I was a few years past residency, and realized that I needed something beyond just the clinic. And from that point, began to engage in clinical trials and other clinical research. So I think I'll stop here and just be open to questions if you have any, and if you're thinking about psychiatry as a possible specialty. If not, it might be very easy. I mean, there are a lot of other very interesting specialties. I should point, I actually rotated through ophthalmology as my last specialty, and that would have been very attractive if I had it earlier. But I have to say that psychiatry, I've never been bored. I've had many, many years of work in the field, and have always been engaged and had something interesting to do, both clinically as well as interesting questions to explore.
Thank you, Dr. Baker. We have some questions in the chat for you. The first,
okay, maybe you can please read them, because
for sure, definitely. Hugh is asking, do you find that seeing patients in distress takes a toll on you?
Somehow I seem to be, and that's probably something you should think about if you're going into psychiatry. I seem to be fairly, there's something about my makeup that permits me to see patients in emotional distress and maintain a lot of internal equanimity. More so probably than many people. For example, post-traumatic stress disorder, which I ended up really focusing on. You hear many very sad or very difficult stories. But somehow I'm able to listen to the stories and to remain remain calm and convey that to the patient. Often patients might be in tears, particularly in treating post-traumatic stress disorder, where if you're the first person who they tell you about the trauma, almost invariably they will be in tears. I keep the Kleenex near their chair. But I find that I'm able to do that without a problem, and I don't tend to carry it home or carry it as a burden. What I do enjoy is seeing people get better over time with the various treatments.
Thank you so much for sharing that. Another question asked by William is, does one need an extensive neuroscience background before pursuing the field of psychiatry?
I don't think you need one to start with, but psychiatry is again sort of re-emerging or coming closer to neurology. The neurobiology is becoming more evident, so that you really do need for giving medication treatments to have a neuroscience background to understand what they might be doing. Nowadays in psychiatry, a lot of brain stimulation techniques are being used, and it's helpful to have an understanding of neurocircuits and brain physiology for that, so that if you don't have a background, you'll need to obtain it, but you'll get some of that in your training.
Okay, thank you. I think Alec has a question. He put his hand up. You can feel free to unmute yourself if you'd like to ask a question.
Hi, yeah, thanks so much. Just wanted to speak mine out loud because it's less of a question. I was wondering, Dr. Baker, if you could kind of speak a little bit about walking the line between prescribing a treatment for a patient, like pharmacological therapy, which you obviously kind of want to walk the balance between side effects and how is this going to benefit their life. For instance, bringing it back to having a patient with PTSD in tears at your first consult. I guess I'm kind of asking, where do you kind of define a threshold of I'm going to prescribe this person a psychoactive medication or another form of treatment?
Okay, so those decisions, of course, are critical, and there are some patients who can manage without medication. Some of this, to some degree, depending on what sort of medical system you're in, and they're each different in Australia, Canada, and the US, depends on the way, depends on funding. So, for example, in psychiatrists being more expensive, they certainly in large systems like the one I work in for the treating PTSD and TBI, they tend to give the psychotherapy to psychologists or to social workers, and and I will get the patients who fail those treatments. And when I was in Cincinnati, I actually did all the intakes on patients, and then we made the decision as a team about where to go with medication versus therapy, versus versus therapy. Let me say it's usually it's often a combination. But some people don't need the medication for something like PTSD. They can get better with some evidence-based psychotherapies like prolonged exposure or cognitive behavioral therapy. However, the other aspect of this is it also depends on your patient. I work very closely with my patients to form a close alliance, and a patient needs to be wanting and be ready for medication, and not be resisting or wanting to try something else. So as long as somebody is safe, isn't acutely suicidal, there's no reason not to work rather flexibly. Now, I don't frequently currently treat bipolar illness or psychotic disorder. There's less leeway in those conditions, and often medication is really essential, and is essential even if a patient may not want to be taking medication.
Thank you. Another question by Nishi is, what are your thoughts on new acute treatments such as ketamine and psychedelics?
Okay, I actually have a bit to say about that. We have what we call a neurostimulation unit in our VA that treats the severely depressed and people with PTSD who may be depressed or suicidal. And I, being a fairly cautious person with medications, had not sent anyone to the ketamine treatment until the last year. And I have been very interested and very impressed with some of the outcomes. Now, I don't, the evidence base for these is very early. And when I'm saying these, I'm talking MDMA or ketamine, or I think some people are using psilocybin. So the only one I have experience with currently is ketamine, or sending people to transcranial magnetic stimulation. I ended up sending 2 patients of mine who were really quite ill. And they both had not just plain PTSD, but they had traumatic brain injury as well. And that had been documented by magnetoencephalogram scans. And so the first patient had tried almost every treatment, had tried all kinds of the really state-of-the-art verbal treatments. And I was giving him standard PTSD treatments, which are serotonin reuptake inhibitors, as well as prazosin. Prazosin really is wonderful for nightmares. But he still had a lot of nightmares. These folks often get up in the middle of the night and they end up binging because they're up. They are just not comfortable. And so I ended up sending this person to treatment, and he's substantially better. The problem with the ketamine treatment that we've seen so far is that you need the boosters. You can't. He feels better for approximately 10 days, but he has about 4 days of feeling like his old uncomfortable self before his next booster treatment. They've offered him more frequent boosters, but he's trying very hard to not require, every week boosters rather than what he's getting, which is every other week boosters. The other patient that I had was very worrisome. He was very depressed, quite suicidal, not going outside of his room, had lost about 10 pounds, despite all the medications, the standard medications that I could give him. And I decided to send him, and he went for treatment. And again, he has substantially improved. Now, we have a couple papers recently that are coming out. They're clinical papers. They're not papers that use a control group. But what is been being shown, it seems, in our ketamine treatment clinic, is that the patients with depression, they respond quite quickly to ketamine within a few days. Our PTSD patients, like the two I sent, take quite a longer time frame to get to improve. And frankly, the second patient that I talked to you about is continuing to improve even after months. And I'm not sure why, unless I've just sent such chronic and sick patients that it's just taking longer. But so I've become open to thinking about using these treatments, and will continue to send patients who aren't responding to the standard treatments.
Thank you for your response. Another question by Johnson is, what are your thoughts on the major changes the field of psychiatry will adopt within the next 10 years when we will be starting our training and practice?
Well, we're learning more and more about brain circuits, the brain, and potentially the cells that are contributing to some of the maybe circuit abnormalities. And so hopefully we'll be able to improve the efficacy and the specificity of some of these treatments. We'll be able to predict who responds and how to orient, for example, some of the brain stimulation treatments in a way that they target the correct areas in the brain and reduce side effects. And again, the other issue with this is, of course, we are working hard, at least where I'm located, at trying to understand how to integrate psychotherapy with some of these newer treatments.
Thank you. Does anyone else have any questions for Dr. Baker?
If not, then we can move on to our next speaker. Thank you so much, Dr. Baker, for all your wonderful insights and taking the time to share your experiences with us today. We really appreciate that.
Okay, I'll just end by basically saying that if you're interested in this field, you will not be bored. It is a very wide open field for research as well as clinical interest.
Thank you so much, Dr. Baker, for your time.
Right. Thank you. Bye.
Thank you. Thank you.
Angela, you can see my screen there?
Yes.
Great. Well, I'm now delighted to introduce our second speaker of the day, which is Dr. Byrne. He's a Maine professor of psychiatry. I would like to also just quickly add that the Maine family has donated the land on which the University of Queensland stands today. He is also the head of Academy of Psychiatry and University of Queensland director. He completed a fellowship of the Royal Australian and New Zealand College of Psychiatrists and obtained a PhD in psychiatric epidemiology at the University of Queensland. His clinical work was initially in drug and alcohol psychiatry and general adult psychiatry. In 1995, he established the Geriatric Psychiatry Service at the Royal Brisbane and Women's Hospital. Over the past decade, he has been increasingly involved in geriatric forensic psychiatry, assessing older people charged with serious offenses, including murder. So without further ado, we welcome Dr. Byrne today. Thank you so much.
Thanks, Jacob and Angela, for the kind invitation to speak today. Can you hear me clearly?
Yes.
Good. And welcome, everyone. I got into psychiatry by a slightly different route, and some of that was due to the fact that the Australian system is different from the US system, and some of that was just me. I went to medical school straight from high school. There wasn't any pre-med or anything like that. There was no prior degree required. You could go just straight from grade 12 in high school into the medical degree. And when I was doing it, it was a 5-year program. I added a 6th year to do a bit of research into immunology, which made me think that wasn't my future. During medical school, which was in Sydney, I had some quite influential teachers, particularly in psychiatry, which I found fascinating. And I certainly echo Dr. Baker's view that you'd never be bored in psychiatry. So I was fascinated by that, but then I put it to one side. I didn't really understand how you got to become a psychiatrist. I then did an internship after I'd got my medical degree in Newcastle in New South Wales in Australia. And that was quite interesting too. And I'd met my future wife at a conference of the Australian Medical Students Association, because I was the president of the Medical Students Society at the university in Sydney that I went to. And she was something high up in the University of Queensland Medical Students Society. So we met and ultimately we married, but she was in Queensland, I was in New South Wales. So I decided I'd come up to Queensland, warmer climate, cheaper houses, etc. I didn't know about the floods. And so I came up to Queensland and did another 2 years as a junior house officer and a senior house officer. So in all, I did 3 years prior to specialising in psychiatry. And I did a lot of internal medicine, particularly cardiology. I did even terms in cardiac surgery, all sorts of things, actually, and a term in psychiatry as well in the course of that 3 years, and found that the psychiatry was far more fascinating than the cardiology, much more interesting. For me, anyway. I'm sure there are people who find interesting cardiology, but I just couldn't find it. It wasn't that I couldn't do it, I could do it, but I just wasn't interested. So I decided to do training in psychiatry after those first 3 years as a doctor. And so I entered the Australian and New Zealand psychiatry training program, which is a 5-year program. And that program specified certain rotations. it didn't specify where you had to do them, but you had to accumulate them over a minimum of 5 years. Most people took 6 years. Luckily, I got through in 5, but it included child psychiatry and adult psychiatry and forensic psychiatry and geriatric psychiatry and consultation liaison psychiatry, which is sort of general hospital psychiatry, and several other things. So it was quite a varied program over the 5 years, during which time you're paid reasonably well, not paid as well as you are when you're a psychiatrist, but paid reasonably well. And I was very fortunate that I didn't have any student debt, because when I was at university doing my medical degree, the government of Australia kindly decided that all university would be free to the students. There'd be no tuition fees. You had to pay for your living expenses, accommodation and everything else, but you didn't have to pay tuition. That only lasted a number of years and it's gone now. But so I wasn't left with any debt, so I didn't have to consider debt repayment in my choice of specialty. So, you know, if I had a massive debt to repay, maybe I would have gone into cardiology or gastroenterology or a procedural specialty. I could put stents into people's coronary arteries and make a lot of money, but I didn't have to do that. And also because I was about to be married to another doctor, there were going to be 2 medical incomes in the family, which also took the pressure off my specialty considerations. So it gave me free rein, really, just to think, what would I like to do? And I thought, well, I'd like to do psychiatry. I enrolled in the 5-year training program. I did the 5-year program, did all the examinations. I did supervised psychotherapy. I had a Kleinian analyst who was the psychotherapy supervisor, which was slightly weird, but interesting in its own way. And I did some elected terms up in Queensland, which set me up for then moving to Queensland and doing my psychiatry training ultimately. After I finished my psychiatry training and I had my fellowship of the Royal Australian and New Zealand College of Psychiatrists, that's the sort of ticket to be a psychiatrist in Australia or New Zealand. I then got a position as a research position at the University of Queensland and the Royal Brisbane and Women's Hospital. And I was also a consultant psychiatrist at the hospital. And so I did a couple of years in drug and alcohol psychiatry and about 5 years in general adult psychiatry. And during this time, I was working on my PhD. So I got my PhD. I then did some additional study overseas. I went to Cambridge University in the UK for 6 months. I did a summer program in biostatistics at Harvard, and various other things to add value to my training. And gradually over the years, I conducted research and saw patients and set up a private practice outside the hospital, published papers, wrote books, and gradually went up the university hierarchy until I became a full professor. And then more recently was given this main chair of psychiatry, because the main trust is a trust set up by a wealthy family who donated a dairy farm, which is now called the University of Queensland, many years ago. So in my day-to-day life now, I've got several hats. I'm the professor of psychiatry and I'm the director of the old age or older persons psychiatric service at the Royal Brisbane and Women's Hospital. I do private practice in old age and forensic psychiatry. I see patients for the Supreme Court. I write reports. I go to court and give evidence. I treat older people with all sorts of mental disorders, the whole range. And the interventions used include psychological and behavioural interventions, medication, and ECT. I supervise trainees in psychiatry. I supervise PhD students, whether they're medically trained or not. And so I have what I think is quite an interesting life. I think the characteristic which helped me be reasonably successful was curiosity. I was a curious person, and really I wanted to avoid being bored, and I haven't been bored, which is good. And my curiosity is, you know, satisfied every day at work, basically. So I don't really feel that a lot of what I do is routine. There's always something interesting coming around the corner. An interesting patient with a clinical problem, an interesting older person who's, chopped someone in the head with a tomahawk. And the question is, why do they do that? All sorts of interesting things. So I don't have a problem with boredom. So I'm not a person prone to accumulating money just for the sake of it, or using drugs and alcohol because I've got no other excitement in my life. I've got plenty of excitement, low level excitement in my working life, and that's what I enjoy doing. I could go on, but I think just like the previous speaker, I might stop and then see if you have any questions or comments.
Yeah, so feel free to use the chat and I can direct the questions if you guys have any. I personally have a question. I know that you've recently published anxiety in older people, looking at it from a both clinical and research perspective. Just wanted to learn a little bit about how that came to be in your work in that field specifically. All right, so thank you for that question. I've been involved in writing 3 other books before, so I sort of knew the game, how to publish a book. A colleague of mine who's a professor of psychology at the university have been collaborating on research studies for many years. And we also devised a scale called the Geriatric Anxiety Inventory, the GAI, which has been translated into more than 20 languages and is available all over the world, including in the VA system in the US. So we've been researching anxiety in older people for years now. And we knew a lot of people who were in that field because we'd presented at conferences all over the world. We'd written a lot of research papers, more than 30 at least, together on the topic of anxiety. We'd supervised a lot of PhD students on this aspects of the topic. We were sort of still engaged in neuroimaging studies in anxiety in older people and anxiety in various conditions like Alzheimer's and Parkinson's disease, etc. So we did know a bit about it, and we just thought, well, it's about time this was all written down before we retire. So we put together a book proposal. We sent it to Cambridge University Press. Why Cambridge University Press? Because they're the publishers of one of the main scientific journals in geriatric psychiatry. So we thought they were sympathetic to the topic, and they published a lot of our papers. So they knew we weren't just mucking around. And so we put a book proposal to them. They said, fine, contract. And then we set about contacting the potential chapter authors all around the world. And some of those people said yes, some of the people said no. And then we invited them to submit their chapters, and we chased them up quite a bit. And then the book was published. I mean, one problem with publishing at the moment is COVID, of course, because there's no international face-to-face conferences going on, and that's where you'd mostly be promoting your book. You would have large publishers like Cambridge University Press would have a stall at large conferences, and you'd be able to go there and talk about your book and that sort of thing. But of course, it's all online now, so it's much less satisfactory, I think, when you're writing a book like an academic book, which is going to have, a small readership, because only certain people will be interested in buying it. It's not going to be a airport bestseller. Awesome. We do have another question here. Could you describe the general process of psychiatrist specialty training, the program in Australia specifically? Yeah, the current situation, now this could change in the next couple of years, but because there are some changes mooted, but currently you have to have completed your medical degree and be registered as a medical practitioner and have done your intern year, just the 12 months of your internship. And when you're in the second half of that 12 months of internship, you can start applying for positions. And some of those positions will be attached to training programs in different specialties. So
So in the middle of your first year, when you're an intern, you express your interest, you apply for a position in a hospital, and then you also, at the same time, in parallel, apply to the Royal Australian New Zealand College of Psychiatrists training program. And they have interviews where they select people to become psychiatry trainees. And so in order, you have to provide documentation, a CV, academic record, referee reports, have to provide evidence that you're not under a cloud of some sort legally or with the medical board. And then they interview you. It's a fairly rigorous interview where they look at your suitability to be a psychiatry trainee. Now, Dr. Baker was talking about her own personality as being suitable for coping with distressed patients. Well, that's a significant issue in selecting trainees. We don't want people who are going to collapse on their first day because of the stress of the nature of the work. So you do need to be a person who's reasonably secure in themselves and who's not battling too many demons of a psychological sort if you're going to help other people who have problems. So the selection interview is designed to try to identify people who are more suitable for psychiatry training. And once you've got a job in the hospital system as a psychiatry trainee and you've been accepted by the College of Psychiatrists as a trainee, as soon as you've finished your 12-month internship, you can start your psychiatry training. Alternatively, you can do what I did and do more than 1 year as a junior doctor to gain more general medical experience so that you feel more secure as a doctor before you start turning into a psychiatrist. The program itself, as I said, it's 5 years. It's got exposure to different sorts of psychiatry over the 5 years. Some elements are compulsory and some are optional. There's a series of written exams and clinical exams, vivas, OSCEs, that sort of thing. So it's quite a thorough assessment process. There's lots of workplace-based assessment as well. There's a formalised training program, a set of weekly lectures, if you like. So it's quite well organised. The only thing that isn't well organised, as you may have seen in the press earlier this year, was they changed their OSCEs from face-to-face to online, and the company that they used to deliver the online platform didn't have enough bandwidth and the whole thing collapsed. So, you know, that was very disappointing for the trainees. The same thing happened at the College of Physicians and the College of General Practitioners. So it seems like they're using the same firm with the same inadequate bandwidth. So we've made our displeasure known to the college about this.
Yeah.
All right.
Wonderful. We got another one from Alec. You kind of touched on this already, but can you go into a little bit more detail about a day in the life of a forensic psychiatrist?
All right. Okay. Well, I'm not a full-time forensic psychiatrist. I do it as part of what I do. But forensic psychiatrists, their life would depend on whether they're in the public sector or the private sector. If they're in the public sector, so if they're employed by a state government hospital, for instance, they would go to the hospital like any psychiatrist would go to their hospital, but the patients they'd be seeing would be behind lock and key. So the hospital would have very high fences, it would have security guards patrolling and all of that stuff. There'd be very rigorous security procedures. You would not be able to take lots of things into the place that you would normally take to work because of security concerns. And so there'd be a mixture of nursing staff and allied health staff and security personnel. The patients would be under very close scrutiny. Many of them will be on charges of murder or attempted murder or rape or various other pretty serious offences. They may not have been convicted yet of those offences, but usually if they're there in a security hospital or a forensic hospital, usually the evidence is pretty substantial that they did it. Otherwise, they wouldn't be there. So So if you were employed there, you would just go into work at the hospital each day and see patients and treat them. The main difference is that not only do you have to assess and treat patients, and it could be with psychological treatment or behavioural treatment or drugs or ECT, but you also have to write reports, very detailed and very accurate reports about the patient, which will be then used in the legal system by the Supreme Court in Queensland. So we actually have a separate court, part of the Supreme Court, called the Mental Health Court, which other states of Australia and other parts of the world don't have. It's not a diversionary court where you get drug addicts and you send them off to a program instead of putting them into jail. It's not that. It's to decide if a person is unfit for trial, so they shouldn't ever stand trial on the charges, or whether they were of unsound mind at the time they committed the alleged offence. So, you know, at the time they killed someone, were they hearing voices, or did they think they were going to be killed, or something like that, which might mean they were of unsound mind. And if they are found by the court to be of unsound mind, they never go to trial in Queensland, but they stay in a forensic hospital. And if it's a serious offence like murder, they stay in hospital for as long as they would have stayed in jail. So it's not a sort of get out of jail card, actually. You end up being in a forensic hospital environment. Now, if you're in private practice as a forensic psychiatrist, which is my situation, so I do a small amount of private practice as well as my public practice. And in my private practice, I do a lot of forensic work. So I write reports. I don't look after people who've been charged with murder and who have a mental illness, but I see them as an independent assessor. And I write an independent report, usually, to the court, directed to the judge. And then the judge can use that report and reports from other people, perhaps, to make a decision about what to do with the person or the patient. Occasionally, I might write a report for the prosecution or the defence in a case where it isn't before the mental health court. But generally, when it's before the mental health court, I'll be writing for the court, not for the defence or prosecution. Does that make sense?
Yep. Awesome. The next questions are a little bit more in regards to research specifically. I'll just kind of combine these two. A University of Queensland student, a med student, was asking about psychiatric research projects at UQ, specifically with the student portal. I'm not sure if you're familiar with that, or they asked if rocking up straight to RBWH mental health unit or trying to go that route would be better for someone to obtain some research.
I think the UQ route would be better than the RBWH route, because most of the psychiatrists at RBWH are not doing research.
Okay.
So we're not doing, yeah, they're mostly not doing research. So the UQ route would be best. I mean, the fact that the projects don't appear on that website is probably because the researchers are very busy and, you know, they're fully committed or whatever. I suspect what's going to happen in the next couple of years, between now and 2023, or, you know, this year and next year, is that you'll see more research opportunities appear on that portal for psychiatric projects, because we certainly have both paid academic staff of UQ and also academic title holders who are engaged in teaching as part of their clinical activities, but who are doing a lot of research. It's just that they haven't to date directed that research towards medical students. They've directed it towards psychiatry trainees or PhD students. So it won't take much for them to be redirected to say, look, develop some of your projects which are of a size, you know, not too big, and a type that is they can be completed reasonably quickly, that might be suitable for a medical student, because often the projects are too big and too lengthy to be suitable for, you know, the time that's available for a medical student. So I think because the curriculum is changing at the moment and the emphasis on research is for students, I mean, is increasing. So I think you'll probably find more of this going on. The other thing that's happening is we're having quite a lot of staff turnover in psychiatry at UQ. And so we've just been interviewing over the last few months for new staff. And so I'll be directing the new staff to be more visible on those portals in terms of offering programs So I suspect you're probably going to see more of that sort of stuff. There isn't much there now, I know, but yeah.
Okay.
So I don't think it's the hospital people generally.
Okay, great. And just to piggyback off that question, someone's also asking about, first they're asking, is it viewed as a negative to be an older applicant to psychiatry specialty training? And then secondly, talking about whether a PhD is at all advantageous when applying. I know you briefly touched upon that in your last response, but.
Well, the College of Psychiatrists, by law, is not allowed to discriminate on the basis of age or gender or anything else for that matter. But so it's a pretty broad church, actually, the College of Psychiatrists. There's huge ethnic diversity. There are more women trainees in psychiatry than men. Well, most years there are. So gender equity is not a problem. There's great acceptance of LGBTI and people with other physical disabilities. So I reckon compared to some other medical specialties, it's much more open and diverse. I don't think age, I mean, the only issue about age is that, you know, it's a 5-year training program. You don't want to start it when you're 75.
Yeah.
I mean, that's just common sense. It's not a matter of discrimination. So I don't think an older person's going to be, there's no age thing. How do they know your age anyway? You don't have to tell them, as far as I know. It's not, they're not allowed to ask your age or your marital status or your, you know, gender for that matter. So no, I don't think that's, now having a PhD in animal physiology, I don't see how that's a disadvantage. I mean, obviously they prefer a PhD in neuroscience, but not many applicants have PhDs in anything. So, and one of the criteria is what's your academic record like. So if you've got a PhD and a medical degree, that sounds pretty good.
Yeah.
I'd give you good marks if I was on the panel.
And then finally, we just have the last one here for you. Someone was asking which hospitals in Queensland specifically would you recommend to be good in psychiatry for resident? I know we don't have there's not a really residency process here, but I guess to do your training in Queensland.
Well, look, I think the place to train is the place, or are the places which have a good reputation for looking after their trainees, but where you're close to your friends, and if your family's here, your family. So I think the biggest problem is when people are not supported outside of work and not supported at work. So I don't think there's as much bias against, when you say international students, you're talking about North American students, Canadian and American.
I believe that's what they're referring to.
Yeah. So when international students first started doing medicine in Australia, there was a little bit of negativity from Australian doctors about why we should be training people who will go back to the US or Canada. But as time's gone on, that's lessened and lessened, I think, so that there's a few recalcitrants who still think that way, but most people don't. We've got used to Canadian and US accents now, and we see them on television anyway, but we've got used to them in the hospital. So I don't think there's the same issue that there used to be. Now, the hospitals which are the best hospitals to do your psychiatry training changes over time. So it's not static. So once upon a time, the best place to do it was the Prince Charles Hospital in Brisbane. Now I believe it's probably the Royal Brisbane and Women's Hospital. There have been times when it was the Princess Alexandra Hospital, but I don't believe that is the case at the moment. I'm saying this not because of personal knowledge, but because of what the trainees who I supervise tell me if they come from one of the other places. So they're telling me that they're coming to the Royal Brisbane and Women's Hospital because at the moment it's the best place to train. But you know, you guys are a few years out of psychiatry training, so by then it could have changed.
Sure.
I'm talking about big city hospitals, obviously. It's quite hard to get the full experience in rural and remote places. And there are far fewer training places in rural places. I think the exception is probably, I mean, the Golden Sunshine Coast, the new hospitals at the Golden Sunshine Coast, north and south and north of Brisbane, provide solid training. So, you know, I don't hear terrible things about them. Cairns Hospital in far north Queensland is said to be good as well, although I haven't had direct contact with trainees from there for a couple of years, but people tell me that it's a good place to train. So to summarise, I would say several of the big hospitals in Brisbane, the Gold Coast and Sunshine Coast University Hospitals, and the Cairns Hospital. But amongst those, at the moment, and it won't be for all time, the Royal Brisbane and Women's Hospital seems to be a neck or two ahead.
Awesome. Charlene, I believe you have your hand up if you want to unmute yourself and ask a question.
Yeah, with regards to that, it's because I was told, I'm actually from Singapore, so I was told by an intern here that, to be honest, like the metro hospitals, they offer really limited positions, intern positions for international students. So, and they were telling me that if I have my mind in psychiatry, the hospital that I work as an intern would be good to work as a JHO as well. So I was just wondering, apart from the large city hospitals, which you've already mentioned, the Sunshine Coast, Gold Coast, and Cairns, was there anywhere in, I guess, in Queensland, like, what about Ipswich and Logan Hospital?
So Ipswich and Logan hospitals have very busy psychiatry units, okay? Mm-hmm. So the problem is not the patients. The patients are good. You know, there's lots of them. There's lots of experience to be had. The trouble has been that there's been significant staff turnover. So there's been changes in the staff, in the psychiatrists, quite a lot of changes over time. So there's not the same stability of medical staffing as there is in the larger places. But there's sort of nothing intrinsically wrong with the pool of patients who are coming into those hospitals and the variety of things that are wrong with them. Look, I don't know about this international student thing, Charlene, that you're talking about. And let me tell you why I don't know about it. I don't know about the internship because my main contact is with, I do have interns, but my main contact is with the trainees who are doing psychiatry. And my current trainee is from Germany, and my previous trainee was from Hong Kong.
Oh, okay.
So, does that tell you something? I'm the professor of psychiatry, and that's the trainees that I'm getting, right?
Yeah.
So I'm, I don't think there's any problem with international, people of international origin getting jobs in the training program. I was asked to give a lecture before COVID started in Western Sydney to a group of doctors, and there were, 200 doctors in the lecture theatre, and I saw one Anglo-Celtic face other than my own. Okay.
Okay.
So I think there was, quite substantial diversity, put it that way. Yeah.
I'll just add, Charlene, from my understanding as well as an international in Australia here, in our intern year, in terms of the ranking, we will be on the lower end of that compared to domestic students. But after that first year of intern training, we're on the same playing ground or level as the rest of the students when we're applying for trainees. I know we have to do some years as a general registrar and whatnot, but from my understanding, it's only in that first year as an intern where we may be allocated in a more rural area just for that first year. And then when we do apply.
I don't think you can't really be sent to the remote areas as an intern because the remote areas can't provide the rotations that are required for an intern. Yeah. So, you could be sent to a regional area, as like Ipswich or Logan or Toowoomba somewhere like that, you could be sent there. I reckon if you were sent there, if the system is rigged in that way, if you were sent there, you'd probably get better exposure to patients. You'd have more responsibility. You might have less supervision, but you'd have more responsibility. So I'm not sure it would. I mean, it sounds like a disadvantage, but it might turn out to be an advantage, because you might end up being a more confident doctor with a wider range of experience, and a doctor who's able to take responsibility earlier than some of your colleagues who've been mollycoddled in the big city hospitals. So I don't know. I certainly worked in my internship was at Newcastle, which is in regional New South Wales, not the big city, really. My wife went to Gympie, I think, which is not the bright lights, and now she's the medical head of the Prince Charles Hospital. So I don't know. I just don't know that what you're saying. Maybe what you're saying is right, Jacob, that you've got this thing that means that you're less likely to get your first choice on the intern ballot, but I don't think it wrecks your career. Yeah. And as you say, in the second year, it's all to do with your application and how you scrub up. It's not to do with whether you're at Ipswich, Logan, or the Royal Brisbane. I mean, I can tell you there's plenty of interns who are not that crash hot at the Royal Brisbane and wouldn't be re-employed there the second year, So and in the second year, the big hospitals in Brisbane, for instance, are desperate for junior medical staff.
Great.
They're quite desperate for them. So and that's why they're importing doctors from the UK. Every year they're importing doctors from the UK, even if they have to now do quarantine and all this stuff. Well, they don't now, I suppose, but they did. So that's a sign that the hospitals can't get enough local doctors. So they much prefer a local graduate, even if they're not an Australian citizen.
Mm-hmm.
Okay, great. Thank you so much, Dr. Byrne and Jacob.
No problem. Well, thank you so much, Dr. Byrne, for your talk and for sharing those insights and taking the time to speak with us. And
my pleasure.
Yeah, very, very great. Angela, we will just transition to a short little end here with our final speaker. I'll just share my screen.